So, hello friends. So, I'll be talking on this VExUS score in shock resuscitation. So, if you recall, I had given a overview of VExUS in a previous video, maybe 1 year back. So, this talk is similar, but we would talk on the utility, how VExUS can be utilized in resuscitating shock by citing two examples. And then we'll talk about what are the limitations of VExUS and what are the take-home messages. So I wish to acknowledge my colleague, Dr. Megha, who helped me develop this content. So as you know, the tools that we have at this point of time, see, for just to give a background, we have a lot of tools to assess the fluid responsiveness. But we need to have tools to ascertain fluid adequacy and when to stop resuscitation. So for that, so most of the cardiac output responsiveness with the fluid bolus, which we call as fluid responsiveness, measures the forward flow. And we need to check on the backward flow also, which is determined by venous congestion. So the forward flow is what we ascertain by doing fluid responsive test for fluid responsiveness. So we need tests for backward flow, which is measured by venous congestion. So that is the quintessence of principles of VExUS. So the full form of VExUS is venous excess ultrasound. So that is the acronym for VExUS. So the tools that we had until now to ascertain that somebody is euvolemic is looking at the IVC, because we knew earlier that IVC less than 1 centimeter pretty much corroborated with less CVP, and if IVC was more than 2 centimeters, we knew that CVP was high and they are euvolemic. So this was the measure that we were using. Of course, we were using other tests in IVC like IVC variability index, which is maximum IVC diameter minus minimum divided by mean. If it's more than 12%, we knew it was fluid responsive. And we had IVC distensibility index in ventilated patients, which is maximum IVC minus minimum divided by minimum. More than 18%, we called it as fluid responsive. And in spontaneously breathing patient, we used collapsibility index, which is maximum IVC minus minimum divided by maximum. If it's more than 40%, we called it as responsive. But these were the tests that I'm sure many of the intensivists are using it. So, and we needed the test to understand the congestion. So, for that, we were looking at IVC. But what we realized is in spontaneously breathing, IVC diameter is insensitive and not necessarily may reflect true fluid responsiveness. And if the IVC diameter is more than 2 centimeters, then we know there is a venous congestion or CVP is high. So VExUS is a 4-step protocol where we start, the first step in VExUS is looking at IVC. If IVC is more than 2 centimeters, then only we can proceed with going to step 2, step 3, and step 4. Because we are looking for fluid congestion. So the first step is to look at the IVC, which ascertains whether there is congestion. Cardiopulmonary assessment is by looking at the IVC. Then we look at the venous congestion in the liver by looking at the hepatic vein and in the portal vein. Then we look into the renal venous congestion by looking into the renal vein. So this is the whole concept of VExUS. So the the cardiopulmonary VExUS is by IVC. So liver VExUS is by looking at hepatic vein and portal vein, and the renal veins, we look at renal congestion. So this is a 4-step protocol. So this is again a schematic representation that we look at IVC. It is more than 2 centimeters. We look into the hepatic veins as a second step. Third step, we look into the portal veins, and fourth step, we look into the renal veins. So now the question is, very quickly, we'll run into how we perform a VExUS. So patient has to be lying down supine, and most importantly, if you have to open up the hepatic vein and portal vein, position is very important. For all the trainees, ensure that patient is flexed at the hip and flexed at the knee joint, and preferably they should take a deep breath when the veins open up. So step 1 is you look at the IVC, and I'm sure all of you are experts. You put the probe at the SIFI sternum, and if IVC is less than 2 centimeters, then you cannot go ahead with the VExUS assessment. VExUS score is 0. If IVC is more than 2 centimeters, then you need to grade whether VExUS they fall in grade 1, grade 2, or grade 3, and we need to move to the hepatic vein. So as you see, the hepatic vein branches out of the IVC, and you look into 3 tributaries of the hepatic vein. So there will be a left hepatic vein, middle hepatic vein, and the right hepatic vein. And as you see, the hepatic vein sort of branches out from the IVC, and you would look at that as a bunny sign. So for doing hepatic vein, you need to keep the probe little lateral to the sternum, and you would typically see a bunny sign sort of it's a face of a rabbit, bunny sign. So the two ears are the left hepatic vein and the middle hepatic vein. The right hepatic vein looks like the face of the rabbit. So this is called the bunny sign. And the best way to see is ask the patient to take deep breath, and hip has to be flexed and the knee has to be at the flexion. So this is the best sort of a position. So don't try to look at these veins in someone who is lying down flat, because sometimes it may not be very easy. But hepatic vein amongst the VExUS is the easiest to see. So this is just a video to show you how the hepatic vein looks. As you see, patient is breathing and you'll see the left hepatic vein, middle hepatic vein, right hepatic vein, and this is the IVC. So, and these are the different waveforms which we will talk on. So once you visualize this left hepatic vein, middle hepatic vein, and right hepatic vein, you place the cursor, the Doppler cursor and the sample, and you press the Doppler, you will get a waveform like this. So there is a systolic wave and a diastolic wave. So if patient is normal, there is no congestion, venous congestion, systolic wave is larger than the diastolic wave. S is more than D. And this is how it looks. So there is a S wave which is larger than the D, which is normal. VExUS score is normal or 0. If there is a mild hepatic vein impairment, then there is a reversal. So S becomes small and the diastolic wave becomes larger. So this is grade 2 sort of a hepatic impairment, where if you see in the Doppler, S becomes, so S should be always larger. So if S becomes smaller, there is a reversal. So you call it as a grade 1 hepatic VExUS. And this happens because of increase in the right ventricular pressure and the congestion that happens in the hepatic veins. So because of the increase in the RV pressure, there is a backflow which leads to increased pressure and congestion of the hepatic veins. So S becoming smaller than the D. If there is a severe hepatic impairment, then there is a S wave reversal. So the systolic becomes positive and the diastolic wave becomes negative. And in Doppler, you would see something like this. So this is a severe hepatic congestion where you would score it as a much higher sort of a VExUS score. So there is a S reversal and S becomes positive and D becomes negative. So the if patient has severe tricuspid regurgitation, could be one of the limitations for ascertaining the VExUS score, especially with hepatic vein congestion. So hepatic vein, as I said, is the easiest. It is similar to IVC. Place little lateral to sternum. Ask patient to take deep breath. You will see left hepatic vein, middle and right. Place the cursor along whichever vein is very prominent, ideally middle hepatic vein, and press the Doppler. S should be always larger than D. It is normal. So grade 1 is S becoming smaller than D. Reversal is grade 2 hepatic congestion. So now looking at portal veins. For the portal vein, the position of patient is very similar. Patient will be lying down supine, flexion at the hip, flexion at the knee, but you have to place the probe at the anterior axillary line. So that is the where position. So you place the probe at the anterior axillary line below the rib cage or at around the 12th intercostal space or in the right quadrant of the abdomen. So right upper quadrant of the abdomen, you place the probe in the anterior axillary line. So portal vein would be, then ask the patient to deep breath. So you would see a portal vein, something like this. You will see a red sort of a flow in the portal vein. So then you place the cursor, put the Doppler. So when you put the Doppler, you'll see a diffuse sort of a pattern, which is called a monophasic wave. So there will be a very mild alteration in the systolic and diastolic. And this is called monophasic because everything is positive and there is a mild systolic and diastolic variant. So you get, so there should not be a huge variability between the systolic and diastolic. And this volume you see, you calculate the pulsatility index, which is maximum velocity minus minimum velocity divided by maximum velocity. And normally portal vein pulsatility index should be less than 30%. So that is normal. If it is more than 50%, it is severe congestion. If it is 30 to 49%, it is moderate congestion. So if you put the Doppler, you see a monophasic wave like this with a minimal variation. So if there is a mild variation like this, then you have to look at pulsatility index. If 30 to 49%, then it is grade 1 or mild portal vein congestion. So you'll have mild. So if there is a severe variation where there is a huge peaking of the maximum and minimum wave and the pulsatility index is more than 50%, then it is severe portal vein congestion. So this is about the portal vein. So this is a actual image of patient where we took the portal vein. And as you see here, there is severe pulmonary congestion because there is a huge fluctuation in the maximum and minimum sort of a movement of the waveform. So that's about portal vein. So for the hepatic vein, put at the xiphisternum. For the portal vein, anterior axillary line on the right hypochondrium, right upper quadrant of the abdomen. And intrarenal veins is little more tricky. So patient lies in the same position and put the probe in the posterior axillary line. And you will see a sort of a fuzzy picture like this. You have to place your Doppler probe and the sample at the interlobar veins. And normal intrarenal vein flow will be continuous monophasic flow like this. And so you would see a renal vein flow as a continuous monophasic flow. And if there is intrarenal venous congestion, mild congestion, you will see two waves. There is it becomes monophasic, becomes biphasic with systolic and diastolic wave. So this is mild renal congestion. So where there is renal compartment or renal edema, you will see systolic and diastolic wave. Otherwise, it's a monophasic flow. If it is severe renal vein abnormality, you will only see diastolic phase. You won't see two waves, you will see only diastolic phase. So the Doppler looks something like this. So as you see, this is the hepatic vein. If you see, these are the three Dopplers. The first one is the hepatic vein congestion. There is not congestion because S is larger than the D wave. And this is the portal vein where you see variability is there. Maybe it is grade 2 variability or grade 1 where there is 30 to 49%. And here, if you see renal vein, there is systolic and diastolic wave. So you would call it as possibly some renal congestion that is there. So just a video to show this. So this is the hepatic vein, this is the portal vein, monophasic, and here you see mainly diastolic present or systolic and diastolic present in the renal vein. So when you look at the VExUS grading, so if IVC less than 2, then there is no congestion. VExUS is 0. If it is more than 2 centimeters IVC, then you go ahead and look at the hepatic vein, portal vein, or renal vein. For any abnormality, you start scoring 1, 2, 3. So if there is hepatic vein abnormalities, put 1. If there is a portal vein abnormality, put 1 plus, or renal vein. So addition of all that gives you congestion. 0 is mild congestion, 1 is moderate congestion, or 2 is severe congestion. If there is abnormal wave in any of these, you score 1 each for each of the abnormal waves and add it up. So if it is 2 and more, it is called severe congestion. So that is the VExUS grading. So based on this, and so they have looked, this has a good correlation with acute kidney injury. So if the VExUS score is higher, so higher is the risk of AKI has been shown in the study. So we look into how this can be utilized in shock resuscitation. So we look into case 1. So this is a 28-year-old female, gravida 5, para 2, 32 weeks with a twin pregnancy who had a postpartum hemorrhage, underwent LSCS. After this, patient goes into disseminated intravascular coagulopathy and gets massive transfusion protocol. So hemoglobin is 6.7, lactate is 11.3. Patient gets intubated, ventilated. And as you see, patient is on effort of 80%, PEEP of 10, maintaining saturation of 94%. And stroke volume variation is 23%, which means patient is fluid responsive. So patient gets 6 liters of fluid resuscitation along with the blood products. VExUS is done. As you see, VExUS is IVC is more than 2 centimeters. And you see the hepatic vein, there is a systolic reversal. S and D are in the opposite, which is a grade 3 congestion. So after this, echo is done, which shows RV dilatation. There is a tricuspid regurgitation jet, and there is a RV dilatation with the movement of the interventricular septum leading to the D-shaped interventricular septum, which shows there is an RV strain. So then a Doppler is done, which shows common femoral vein mobile clot is seen. So CTPA was done, patient had bilateral subsegmental fluid. So this is a patient who was resuscitated with 6 liters of fluid and has developed a PE with RV dysfunction. So treatment, patient was obviously managed with vasopressors because of hemodynamic instability. Because there was RV dysfunction due to PE with a lot of fluid overload, ultrafiltration was done with 5 liters fluid removal. And because patient had PPH in the setting of PE, they could not do anticoagulation, they put IVC filter. So day 3 patient was extubated and discharged 17 days post-op from the hospital. So the learning points in this is, so the VExUS that was done at a stage after 6 liters did show there was a fluid congestion, which was an indicator that patient has to be decongested. So it suggested there was volume overload and echo assessment showed RV dysfunction. So active fluid offloading was done by removal of those 5 liters with ultrafiltration, which improved your LV contractility and LV filling and cardiac output. So basically, VExUS helped us to determine there was a fluid congestion and there are significant offloading of the volume status that had to be achieved in this patient to improve the hemodynamic status. So this was the utility of VExUS. So we look into case 2. So this was a 81-year-old male who is 90 kgs, had a pulmonary artery hypertension with severe MR, undergoes mitral valve replacement and gets 3 units of blood along with FFP, along with cryoprecipitate and platelets. 800 ml of FFP and platelets are given. So he ends up with a positive fluid balance of 2910 ml. Vitals 73 beats per minute, blood pressure 138, 98% saturation. And this is maintaining with noradrenaline and dobutamine at the dosages that are shown. And he's maintaining saturation at HFNO with FiO2 of 40%. Clinical examination shows crackles. So echo done shows good LV function, but TAPC is 13, which indicates there is RV dysfunction because TAPC should be more than 18. Hemoglobin is 9.5, blood urea is 110, creatinine is 2.9. So VExUS on day 1 showed IVC of 25 millimeter, which means he's congested. And hepatic vein Doppler shows S-wave reversal, which means he was congested. Portal vein, more than 50% pulsatility. And renal Doppler showed monophasic flow with diastolic pressure. VExUS was grade 3. So because VExUS was grade 3, patient was started on furosemide infusion and 1200 ml to achieve negative balance of 1200 ml in 24 hours. Day 2, IVC came down to 22. Portal vein pulsatility came down to 37.5. As you know, less than 30% is normal. Then it showed biphasic wave, systolic pressure with diastolic pattern. Blood urea came down to 90, creatinine came down to 2.2. Day 3, they continued furosemide infusion. IVC came down to 15, 1.5 centimeters. And hepatic vein Doppler, S was greater than D, which is normal hepatic vein. Portal vein pulsatility became 20%. And if you see how consequently blood urea continued to come down, creatinine continued to come down to 1.5, and by then patient had achieved a negative balance of 3200 ml in 24 hours. So basically this showed there was a renal congestion and continued diuresis helped improve the renal function. And dobutamine came down to 3 micrograms per kg and CVP also came down to 2. So again, the learning lessons in this patient was how offloading RV was important to improve the LV contractility, and offloading helped in improving the renal perfusion and improving the renal congestion. So because there was renal compartment because of fluid sequestration and reducing the renal blood flow. So this was offset or mitigated by offloading or by diuresing or by decongesting the patient. So this was the learning points. So these were 2 examples as to how VExUS can be utilized in improving the organ function, because here the organ dysfunction was mainly due to the fluid congestion. In the second case, it was due to that. Even in the first case, you saw the hemodynamic instability and the sort of RV failure management could be achieved by good sort of a decongestion. So now there are certain potential pitfalls and caution that one needs to have. VExUS will not be able to differentiate between volume overload and pressure overload. And as for all the intensivists, treatment has to be calibrated in the context of the patient's clinical situation, and the VExUS has to be interpreted in the context of patient's underlying clinical condition. Most important lesson for intensivists, don't look at VExUS in isolation. It has to be in conjunction with good clinical examination, lab parameters, imaging, and echo assessment. Because you saw in the first case, echo assessment was done to ascertain how the heart function was. Even in the second, we had to do TAPC to ascertain the RV function. So all these 4 has to be put into conjunction with VExUS, and it is not a tool to determine the fluid responsiveness. VExUS is only a tool to look at the back end pressure and venous congestion. It's not a tool to assess fluid responsiveness. What do we understand by fluid responsiveness? Improvement in the cardiac output following giving the fluid, and that is not a tool. And the role of VExUS, if you look at the studies, primarily investigated in cardiac surgery, because the second case, as you know, was a cardiac surgery patient, or in the decompensated heart failure. The first patient was sort of a decompensation that happened because of PE. So mainly this has been evaluated in primary cardiac conditions like decompensated heart failure or post-cardiac surgery sort of a patients. And these are the patients where VExUS has shown to be of value. So the take-home message is VExUS is a tool to VExUS is looked at as a tool, as a stop point, as a procedural, as a procedure to assess when to stop fluid resuscitation. And it is to identify a group of patients who will tolerate and who would benefit from de-resuscitation or fluid removal. So that is the whole sort of a utility of VExUS. And until now, the focus of all fluid resuscitation or hemodynamic optimization has been on fluid responsiveness, which only looks at the forward flow in the artery. But we have not looked at the tools which looked at the backward flow, which is looking at the venous congestion. And we have to understand the fluid resuscitation is like a double-edged sword, and fluid resuscitation should be tailored to the patient's needs. And possibly VExUS is the key for precise fluid calibration or fluid management. So that would be the take-home message. So thank you one and all. So I request all of you to submit your valuable work to Journal of Acute Care and rehear to this lecture by visiting my website www.drpradeeprangappa.com. So thank you one and all.